One. Sir, we are live now.
Yeah.
Okay.
So,
Welcome, friends. Welcome to this session of Secure Your Foundation lecture series conducted jointly by KS Orthocare, Tamilnadu Orthopedic Society, and Tamilnadu Orthopedic Association, Coimbatore Orthopedic Society, and OrthoTV. So for this session, the topic is going to be Varus and FFT knee, which is probably the most common knee we encounter when we do a primary total knee replacement. And we have a very eminent speaker, a well-known national faculty, Dr BRJ Satish Kumar, who is the secretary of the Coimbatore Orthopedic Society as well. And he's going to talk to us and explain to us about correcting Varus and FFT in primary total knee replacement. And we've got friends from all over the country joining us for this live on YouTube and also on OrthoTV. And Udupet Orthopedic Society, Udupet Ortho Club has made a special arrangement to telecast this whole transmission live in Udupet for all the doctors in Udupet. I welcome all of them. We are very happy to have all of you online as well. So the program will be talk by Dr. Satish, and then we'll have question and answer session, and then we'll have a couple of cases from our side. Dr. Adarsh from KS Ortho can present a couple of cases, and we'll then have discussion after the talk. So without much further ado, I invite Dr. BRJ Satish sir to present his talk.
So thank you, Karthik. I'm audible?
Yes, sir, audible.
Yeah, right. So I welcome all the viewers who are in direct link or who are viewing through the YouTube. I thank Dr. Karthik and OrthoTV for making this arrangement. So before going to this Varus deformity correction or fixed position deformity correction, I just want to tell some fundamentals of deformity correction. Whatever may be the deformity, the etiology, it may be trauma. You may see deformity post-traumatic, or it can be congenital. We do in pediatric orthopedics or in arthroplasty. They all share some basic fundamentals. If you do not know the fundamentals, then it becomes very difficult. If you suddenly want to do the deformity correction in knee replacement, it looks something new and odd. But if you routinely see deformity correction as a bird's eye view from outside, involving the trauma or pediatric orthopedics or any other branch, then it becomes easy to correct the deformity correction to do the same in knee replacement surgeries. So when we encounter a limb deformity, we have to find out where is the location of pathology, whether it is at the segment, that is arm, forearm, thigh, leg, or it is around the joint level, that is the shoulder, elbow, wrist, hip, knee, ankle, or the spine, or both. The deformity involves both the segment and the joint. The first thing we have to find out the location of the deformity. For example, this is the pathology at the segment level. The pathology at segment level is, if it has to produce a deformity, generally the pathology only in the bone. So example, malunited fractures, post-traumatic or pathological, or abnormally soft bone, as you see here in osteogenesis imperfecta, where there is a severe deformity at the leg level, what we call at the segment level. And we also encounter the problem, the deformity at the joint level. So when we say the joint level, we have to think of three things: problems inside the joint, problems just around the joint, periarticular, and problems outside the joint. All these things, one can lead to another. So what do you mean by that? So the intra-articular causes for a deformity can be malunited fractures, joint dislocations, arthritis, and single joint or many joints can be involved. So these are the intra-articular pathology. And periarticular causes means which is immediately outside the joint, and this is the tendon, the capsule and synovium, number 1, number 2 ligaments, number 3 tendons which are very close to the joint. So this periarticular causes always form a secondary component in most of the chronic deformities, any joint which are immobilized, and ligament laxity. Can also ligament laxity or tightness of the capsule. So all those things we can say the periarticular causes that will contribute to a deformity around the joint. Extraarticular causes. Extraarticular causes means it is tendon and the muscle. So the typical example, we have seen cerebral palsy child with a foot equinus deformity of the ankle. Here the joint, ankle joint is normal. The periarticular tissues are normal. Only the tendo-Achilles tendon is tight. That's why the child has got equinus deformity. That's most neuromuscular disorders. The cause we can say extraarticular to start with. And another typical example is a muscle fibrosis. For example, a patient with the idiopathic deltoid fibrosis can come with a shoulder abduction deformity. The deformity, the problem is at the joint level, but the pathology is at the muscle level, the segment level. So that's how we have to know whether the location, the pathology is at the segment or at the joint, and where is the deformity. The limb deformity components, it can be angular deformity, rotational deformity, or both. So if you take knee joint, the deformity can be in the coronal plane, that is the varus and valgus deformity, and there can be a translation. As you see here, the tibia is laterally subluxed. Or the deformity can be in the sagittal plane, fixation deformity or hyperextension. Again, there can be translation. So you can see here the tibia is translated forward. Here the tibia is, there is no translation, but here there is a translation forward. So that is the sagittal plane deformity. And there can be a combination of coronal and sagittal plane. And the axial plane deformity, what we mean is the rotational deformity. The rotation can be external rotation deformity or internal rotation deformity. Generally, the varus is associated with the proximal tibia internal rotation, and the valgus deformity of the knees are associated with external rotation of the proximal tibia. And there can be shortening, what we call transitions in the axial plane, it will result in shortening, and that is more commonly seen in trauma. So when you get a limb deformity, we have to analyze the location, as I said, whether it's a segment or it's articular or both. And if it is around the joint, means it is how much the intra-articular component, periarticular, extra-articular components are contributing to that. And the components, whether it is angular, rotational, and whether it is uniplanar or multiplanar. And what tissues are involved, soft tissues or bone or both. Some of the fundamental principles of deformity correction is we have to do soft tissue lengthening to match the bone length, or sometimes we have to reduce the bone length to match this soft tissue tension. Of course, we have to cut the bone and we have to correct the deformities. Again, this is a very important concept. The deformity can be corrected acutely or gradually. Acute correction at the soft tissue level can be done with the lack of continuity, where you cut the tissues. For example, in clubfoot, after many Ponseti's plaster correction, at the end to correct the equinus deformity, we do tenotomy and we correct the equinus deformity. That is, we cut. There may not be continuity initially, later there can be continuity, or sometimes the continuity may not be needed in some cases. But in some cases, if you want to need continuity, for example, in that cerebral palsy child, we want to lengthen by Arthroplasty. So there the soft tissues are lengthened to achieve the deformity correction. And the bone level acute correction is done by osteotomy, open or closed wedge, and then we fix with the implants. And similarly, at the bone level correction, what we do, we can resect the bones and we replace the implant, by which we correct the deformities. That is typically what we are going to see today, the replacement arthroplasty. So in replacement arthroplasty, we are trying to do acute correction of the deformity. But sometimes acute correction is not possible. We do gradual correction. Gradual correction, soft tissue stretching and splinting. And gradual correction, bony correction is done with osteotomy. And then the manipulation with the wires and threaded pins with the external fixator. The classically it is done with. So these are the basics of deformity correction. We all should know the components and the acute and gradual correction, how we do at what level soft tissue level, bone level, and at the joint level or at the segment level. Now coming to the varus deformity. Varus deformity is the most common deformity what we see in osteoarthritic knee. And like any deformity, I think last time we have seen the valgus deformity. We should know what are the components of a varus deformity. The flexible component can be because of very lax lateral tissues, that is lateral collateral ligament and the lateral side, it can be very lax, or there can be medial bone loss. These are the flexible components. The fixed component is the tight medial tissues, the medial collateral ligament and pes and serenus tendon. And severe varus deformity, there will be tightness, there will be contracture of the cruciates also. And this is the anatomy what we should know. The medial collateral ligament, the superficial part, the deep part, and the posterior oblique ligament, and this is the pes and serenus tendon. These are the medial structures that will be tight. So if a patient comes with varus deformity, clinically we have to see whether what is the patient stature, short, and obesity, and whether if there is any generalized laxity. So this is important because the patient is obese. The patient is obese means, and that means you have to, in general, you have to be more careful in an obese patient. And a short stature patient, again, doing deformity correction is generally difficult in short stature patient. You have to be careful. And coming to the locally, we have to see what the deformity is correctable or not. Like same like what we discussed in valgus. You make the patient walk and see. That is the weight bearing varus what you see. Patient is loading the leg and walking. And if lie down, make the patient to lie down and just see how much it is correctable or not. And whether there is any associated fixed flexion deformity or hyperflexion deformity. And what is the range of movement. And in gait, you can see in the gait whether the patient has got simple, what is called a variant of a tender gait or waddling gait that most of these patients with the bilateral varus will have. And some patients will have a significant varus thrust. So if the varus thrust is there, that means these patients will have significant stretching of the lateral side structures. And X-ray, you take a weight-bearing X-rays and full-length X-ray we can take, and you see what is the mechanical femorotibial angle, otherwise the hip, knee, ankle axis, and see what is the quantity of the varus deformity. And we also need to see the medial osteophytes, medial bone loss, lateral opening, lateral subluxation, and if there is any associated femorotibial bowing. So this lateral opening and lateral subluxation suggests that laterally the structures are loose. So in this X-ray, there is very minimal, there is a mild lateral opening and there is a very mild lateral subluxation in this X-ray. And there is not much tibial bowing, and femoral, there is some femoral bowing is there. Because femoral tibial bowing is there means then the extra-articular deformity is there. So even if you correct the intra-articular deformity fully, post-operatively patient may find some deformities persisting that we have to tell the patient beforehand. So the intra-articular steps, again after anesthesia, you give a valgus stress and fully extended knee. How much is the varus correctable? You can check. And before draping, the surgeon has to check this correctability and what is the range, whether there is a full range of movement is there, whether there is associated flexion deformity or hyperflexion deformity is there. So in cases of the mild deformity is anything, say less than 10 degrees, we can call as mild deformity. And the regular exposure, what we do, the proximal medial release, the releasing the deep MCL and part of posteromedial capsule, and then you hyperflex and externally rotate the leg, and you remove the medial osteophytes. And once you do this, and then you again extend and see, most of the time the deformity will be corrected. Even with giving a valgus stress, even before taking the bone cuts, after doing this regular standard exposure, you extend the knee and then give a valgus stress, you will see that the deformity is getting corrected, and you can see some medial gap. So in case of moderate deformities, where the angle is more than 10 degrees and it is around 20 to 25 degrees, we can call this moderate. And severe is more than 25 degrees, we can call it the severe deformity. So in case of moderate deformities, after releasing the deep MCL, we may have to release the superficial MCL also. And sometimes we have to do the release of pes answeriness. And sometimes we require extended posteromedial capsule release. And same thing for severe. But the moderate and severe, even though we say by the radiological thing, the correction of deformity may progress according to this. Because in some cases where there are huge osteophytes, after doing the huge osteophyte, the release may become less. In some cases, you may think it is moderate, but the knee is stiff, you may have to release more. So this is the thing. After doing this regular exposure, if you think the deformity is not corrected, then you have to do the superficial medial collateral ligament release, pes answeriness release, and you can do the posteromedial capsule release. And once you correct the deformity, after that, you can do the bone cuts. And then now you see the extension gap. In severe cases, we may require these things, reduction osteotomy, and the bone defect, medial bone defect need to be addressed. And sometimes we require a sliding osteotomy. So after doing this superficial medial release, you can go for the bone cuts. And after doing these bone cuts, we have to check the extension gap. If the extension gap, the extension gap should be rectangular like this, which you see on this left side. And if it is trapezoidal with a medial tightness, again, we may have to do more medial release. As I said, these are the steps in the further medial releases. The release should be done sequentially in small steps. Frequently, you have to assess the gap. And in patients with the lateral ligament laxity, the lateral opening will be generally more. As I said, patients who are obese and pre-op X-ray is showing significant lateral opening and lateral subluxation. In all these patients, even after doing a good medial release, once you put the spacer, you think it is fine. But if you give a Varus stress, again, there will be lateral open. So we cannot do enormous medial release. So once we do the deformity correction, I think we have to stop the medial release. And in these cases where there is lateral ligament laxity, and we are also doing a medial release, that means we are already creating the extension gap. So we have to do less tibial cut, say up to 2 or 4 mm, and we have to do less femoral cut up to 2 mm. The distal femur cut and the proximal tibial cut has to be reduced. Otherwise, what we have done by medial release is we have matched the medial release with the lateral ligament laxity. In this process, we have created a gap. So we cannot do the standard bone cuts. We have to take less bone cuts in patients where there is an excessive lateral laxity. So as I said, if there is a significant deformity or in obese patients where the shin is not palpable, we can use an intramedullary jig. And more so if there is you think the deformity looks a little bit complex and the torsion deformity is there and the foot also there is a deformity is there. And rather than using a standard extramedullary jig, you can use an intramedullary jig. So intramedullary jig will give you a proximal tibial cut exactly perpendicular to the long axis of the tibia. So in varus deformity, we do not want the tibial component to be placed in varus. Now, after checking the extension gap, you can insert the spacer and you rock the knee. 1 to 2 mm giveaway is okay. But if you cannot insert the spacer on the medial side, you again go back and see what are the structures tight and try to release more. And the medial collateral ligament can get ruptured in cases of varus deformity or in cases of anything, more so in varus deformity. So we have to release the entire medial collateral ligament as a sleeve subperiosteally, so that once we leave that, the MCL sleeve can get reattached to tibia wherever it is released, and we have to restructure it to the extent whatever is possible with the medial arthrotomy. And in post-traumatic varus deformity, there is significant fibrosis and scarring. Because one of the indications what we do is a varus collapse, tibial condyle fractures. So in these cases, the MCL is very much scarred. So you have to do a lot of releases. Even the deformity looks mild, you have to do a lot of releases because it is very much scarred and adherent to the proximal tibia. And many times implants also may be there. And while doing the medial meniscus excision, we have to be careful. If you are a little bit, even if the tip touches there can be mid-substance cut of the medial collateral ligament because the medial meniscus is adherent to the medial collateral ligament. In the body, most of the body it is adherent. So always leave a cuff. As you see here, the arrow mark, you see that at least 1/3 of the meniscus is lying along with the MCL. In that way, you avoid the MCL getting torn, because this is very common. The way rather than releasing, it gets torn and becomes medially very much unstable. Then you have to end up with a constrained. Right. Another thing is if you see that the extension gap is trapezoidal and tight, you do not force and give valgus stress with the insert or without the insert, especially with the insert. The insert has gone lateral side, medial side, the insert is not going. Now you try to give a valgus stress and push the insert inside. What happens? The MCL can get ruptured, especially in patients with strong bones or the patient with the weak bones, like in rheumatoid. There can be medial condyle avulsion. Next, check the extension gap. So generally, in varus deformity, the flexion gap will be balancing will be good. Immediately, it will not be very tight in general, compared to valgus deformity, where valgus deformity again immediately lateral can be tight. If extension gap is good, generally the flexion gap is good in varus deformity. If we find trapezoidal, then you have to release more of the posterior medial capsule. And this is reduction osteotomy, where you exercise this medial condyle edge. As I said, here the soft tissues are tight. You remove the bone, so the soft tissues are getting relatively lengthened, and we are going to shift the tibial component as lateral as possible. So in this way, we do the medial lateral balancing in varus deformities. So this is an example. As a person, 65-year-old patient, pain for more than 15 years. He underwent proximal tibial osteotomy more than 10 years back, but the deformity was progressive with increasing pain and difficulty in walking. So you can see here significantly laterally subluxed with a plate on the medial side. The deformity was around 40 degrees. This is the lateral views. So if you see extensive osteophytes, it is relatively good because once you remove all the osteophytes, you get soft tissue tension is less. The deformity correction becomes slightly easier. If you do not see, if you see more deformity, but the osteophytes are less, that means you have to be careful. You have to do a lot of soft tissue releases. So this is the pre-op gait. So the plan is plate removal. We have to do extensive proximal medial tibial release, and then medial lateral gap balancing, and most probably medial bone grafting, and post-stabilized knee with the tibial stem. That was the plan. So you can see here, plate has been removed, and a significant medial defect is there. So this is after proximal tibial cut, and you can see here in the defect we have made multiple holes, and then we put a bone graft. The bone graft is generally the posterior condyle. In the posterior condyle, we have got a big chunk, and you fix it temporarily with K wire, and then you fix it with screws. Whatever the cut surface, you put the cut surface here, and you make this you make this sclerotic bone, you cut it, make it flat, and to this flat osteotomized surface, and you put this cut surface of the bone, and then fix with the screws, and then on the top, you can make this is the 2 screws has been fixed, and you can see on the top it has been cut. And whatever the minor defect you see, you can fill with the bone graft. Pieces, small pieces, bits of bone graft, you can push small pieces because this matching may not be perfect. And on the top, you can use bone wax so that the bone cement cannot go inside. And this is a Zimmer implant. Stem has been used, and this is at the end of the implantation. So you can see a good tracking. And it's the same thing, the right side knee, and you can see the defect, and the same thing, bone grafting has been done, and implantation has been done, and the tibial component has been lateralized, and this is the immediate post-op. This is the lateral view. You can see the excellent deformity correction, 3 weeks post-op, and this is 6 weeks. And this is 4 years follow-up. So you can see excellent incorporation of the graft, and the deformity correction is maintained. Okay. So coming to the epicondylar osteotomy is not generally done. So in fixed varus deformities, we do medial epicondylar osteotomy when we cannot correct the medial tightness. Even after doing all the release, sometimes the medial it is very tight. So you do the medial epicondylar osteotomy and then do distal advancement. Same thing on the lateral side we can do. If the lateral laxity is too much, we can do the lateral condylar osteotomy and proximally advance it so that the lateral tissues become tight. So this is the medial epicondylar osteotomy in varus deformity. You can see here this space is not rectangular, it is trapezoidal. So you cut the epicondyle here, as you see in the arrow mark. You slide it distally and then fix with the screws. You achieve a rectangular gap. So this is distal advancement of the medial epicondylar osteotomy. And this is the case, as I said, it's a varus deformity, post-traumatic. The 72 years old patient. And this patient, even after doing a good release and PCL release and after doing the cuts, still the medial side was tight. So we have done a medial osteotomy and then we have fixed with 2 screws. And because there will be in post-traumatic cases, always there is a tendency for recurrence. So we have used a stem. So this is the lateral epicondylar osteotomy in varus deformity, where this is the lateral side, and you do the lateral condylar osteotomy, and you shift. Even though we say epicondyle, it's not a small one. You can see a big flap. A big flap has been osteotomized, and it has been shifted proximal, and see that the lateral gap is less. And if necessary, in these cases, whenever you do osteotomy, you have to use intraoperative CM. Okay, that is about the varus deformity. Now coming to fixed flexion deformity. Fixed flexion deformity is next common to varus deformity. Mild deformity is quite common. It is seen in combination with varus deformity. The basic difference we have to understand between the varus valgus deformity and flexion deformity is this. In varus valgus deformity, the deformity axis is coronal, but the normal knee joint movement axis is sagittal. So recurrence after technically good surgery of the deformity is very uncommon. That is, you have done a good job, as you saw the severe varus deformity, and the varus deformity generally will not recur. And unless you have done a very wrong positioning of the implant, varus implantation, then you can get a recurrence of deformity. That also it is delayed. On contrary to this, in fixed flexion deformity, the deformity axis and the movement axis both are in the sagittal plane. So the recurrence is common even after technically good surgery, and the recurrence is seen very early if you do not take adequate precautions. So in fact, the most common recurred deformity after knee arthroplasty is a fixed flexion deformity, because the deformity you have corrected, but the deformity axis and the movement axis are same. In varus valgus deformity, even in significant deformities, we can do acute correction. Only thing we have to see if it is associated with flexion deformity in valgus, there can be perennial nerve palsy. But in severe flexion deformity, especially in some of the rheumatoids, they come, they have been not moving for several years. They come with deformities 30-40 degrees. Acute full correction is very difficult. In mild to moderate cases, it is possible, but severe, you have to be very cautious. It can be associated with neurovascular compromise, or it can be associated with hyperextension instability. And of course, the perennial nerve palsy along with vascular injury. So in fixed flexion deformity, the pathology along with the intra and periarticular, the pathology, significant extra-articular pathology is there. That is tight hamstrings coupled with a weak quadriceps. Even 10 degrees of flexion deformity of the knee will make the quadriceps getting wasted, and this becomes a cycle. So quadriceps wasting, again there will be a little bit overactivity of hamstrings, and this goes on. And this coupled with the rheumatoid process, most of the patients will come with severe FFT. So the tight structures The tight soft tissues can be postomedial capsule, collaterals, and hamstrings and gastrocnemius. Even fascia and skin can be tight in severe deformities. The loose structure is quadriceps patellar mechanism. The bony pathology in FFD is there can be bone loss in posterior condyle or posterior femur. Many times there may not be, especially rheumatoid. The pathology basically starts posterior capsule and posterior synovium, synovitis. And for pain relief, patient starts keeping the knee in flexion and quadriceps wasting. And this all getting coupled and ultimately results in flexion deformity. There can be posterior osteophytes. So the flexion deformity, the problems, there is excessive forces on the joint and easy fatigability, reduced walking speed, all those things. So clinical assessment, we have to check the gait. This is very awkward because when the knee is flexed, then patient, for balancing the thing, patient has to flex the hip. And sometimes the spine also has to be flexed. So the overall patient height seems to be very less with flexion deformity. And most of the patients, if they do not use walker, their gait will be very, very awkward. So we have to see the degree of deformity in standing and lying. The deformity will be generally masked. If the patient is lying down, especially obese patients, they will externally rotate the leg. The moment the leg is externally rotated, varus deformity, valgus deformity, and even flexion deformity, many deformity will get masked. So you see that the patella is facing in lying position, the patella is facing the sky. Then you will find out what is the exact deformity. The varus deformity also will get unmasked, and even the valgus deformity will get unmasked. And the flexion deformity, if you see from the side, then you will know what is the flexion deformity. And similarly, in acute spasm in rheumatoid patients, some patients will have severe FFD. The moment anesthesia is given, the 20-degree FFD will become 0 degrees. It is exaggerated deformity you can see in some of the patients. And clinically, the assessment is the same. You see how much the deformity is getting corrected after making the patient lying down on the bed, and see if there is any associated scars and previous surgeries. And the radiological assessment, you will find it as a notch view. That means the patient has got flexion deformity. You can see the intercalated notch very well. And if you see X-ray like this, and the patient has got a lot of deformity, a lot of difficulty in walking, but X-ray looks no osteophyte, that means you have to go very slowly during the deformity correction because you have to do good soft tissue releases. Then this deformity will get corrected because there are no osteophytes. So in the lateral view, we can see how much is the posterior osteophyte of the distal femur. In this patient, can you see a lot of posterior osteophyte in the distal femur and the distal proximal tibia. So this patient, the deformity correction of the flexion deformity will be easy because the moment you release this, remove all these posterior osteophytes, the tethering effect on the posterior capsule is less, and you will get correction easily. So if the deformity is less than 20 degrees, acute intra-op correction is generally possible. If the deformity is more than 20 degrees, 20 to 40 degrees, we have to be careful. We have to go for preoperative supervised physiotherapy, stretching of hamstrings and gastrocnemius and serial splinting, and try to bring down the deformity and then go for surgery. If it is more than 40 degrees, better to do posterior soft tissue release first, correct the deformity, and then do splint, and then go for TKR. So ideally, the deformity should be less than 20 degrees. Then it is easy to correct the deformity, intra-op acute correction, and to maintain that. Otherwise, we can do TKR even if 70 degrees, 60 degrees we can do. The chance of recurrence is very high. And after that, it's very difficult. Once you have done the TKR, if you cannot get the deformity correction, say there is a recurrence after 2 or 3 months, then it is very difficult to correct that. So patient has to be encouraged for preoperative physiotherapy and splinting. Many patients will be ready for surgery. They want to get the surgery done. This patient, right now patient is in the hospital. This patient came last week for surgery. Both sides she had nearly rheumatoid patient, but there is no active rheumatoid activity now. She came with nearly 30 degrees. So I told I'm not going to go for surgery immediately. So we have applied these knee braces, both sides, and we did physiotherapy for nearly 1 week. And we have brought to about 20 degrees, both sides. And this is the left side surgery has been done. Right side, this patient is planned for the next week. So left side, you can see this is even after surgery, you can see there is some residual deformity here. Some 5 to 10 degrees there, but the patient is, when it is forced we can get the deformity correction. So pre-op physiotherapy and splinting is very important. The deformity is more, especially if it is more than 20 degrees. And post-op splinting is necessary in all the cases. Please do not take pride in telling that there is no need. Yes, you may not need if it is, as I said, if it is only osteophytes, if it is a OA knee, you may not need. But if it is a RA knee, rheumatoid arthritis, knee flexion deformity, it is mandatory to use a splint for at least 3 weeks, maybe sometimes up to 6 weeks. It should be, there should not be any residual FFT, and there should not be any quadriceps lag. Patient should develop adequate quadriceps power. And splinting is done whole day in the initial days, and after 2 or 3 weeks, night splint alone can be done, but night splint is mandatory. Otherwise, patient will flex the knee to reduce the pain, and this will go for deformity correction. And the patient comes for the second follow-up, say after 2 or 3 months, they will come with FFT. So the post-operatively, the strengthening quadriceps is very, very important. So patient has to be advised supervised home physiotherapy. This is mandate. They will tell that we will do by ourselves, but that's not going to work. This patient will go for recurrence, especially rheumatoid patients will go for recurrence. So intra-op steps, same. Most of the time, if there's a flexion deformity, we have to do a PCL release, and we have to do posterior stabilized knee. And when you do the proximal tibial cut, we should not give any posterior slope. If you give a posterior slope, again, that will promote flexion deformity. So you have to give posterior slope if there is a stiff knee. If you want to get more flexion, generally we give more posterior slope. And posterior osteophytes, as I said, the moment you remove these posterior osteophytes, you do the proximal tibial cut, you remove the posterior osteophytes from the proximal tibia, and you do the anterior posterior femoral cut and remove the posterior osteophytes from the distal femur. And many deformities can get corrected if this is arthritic knee. I mean, osteoarthritic knee where there is a lot of osteophytes. And if the extension gap is still less, you think the minimum spacer is not going even after this cut, then you have to do a distal femur cut. You can do the distal femur cut generally 2 mm to 4 mm more. Rarely in big knees, you can do 6 mm. Otherwise, if you do more than 4 mm, it will encroach the attachment of the collaterals. And you can release the capsule from the posterior tibia. And sometimes from the distal femur also. But what I have noticed is even if you do this capsule releases, many times the deformity correction, you may not get it in chronic cases. So increase distal femur cut, it increases the extension gap, no effect on the flexion gap. So this is ideal in case of flexion deformity. If you increase the proximal tibial cut, it increases the both extension and flexion gap. So in extension, you may have correct gap, but in flexion, the gap will be more, what is called flexion instability. So this is finally, as I said, you may have to release the capsule from the distal femur, and the gastrocnemius release. Generally, if you do the gastrocnemius release, it can be associated with instability. And if extension gap is sufficient, then you go for chamfer and notch cuts, and then you can go for trial components. And again, when you're giving a femoral component, there should not be any flexion. If you do not take care, the femoral component itself can get flexed, slightly flexed. And what happens is this flexion of the femoral component will result in persistent fixed flexion deformity. You won't be able to extend because the femoral component is already flexed. So this is the gap balancing chart. And this is commonly seen because many times surgeon does the more tibial cut to accommodate the insert. So extension gap is okay, but flexion there is instability. So in these cases, you may have to increase the femur size so that now increase the femur size, and then you can use the posterior wedge augment so that the flexion gap is reduced. So residual deformity, generally we can leave 10 degrees, not more than that. And again, if you leave any residual deformity, you have to see that patient is getting post-operative proper splinting and post-op physiotherapy. This deformity looks very innocuous, this 10 degrees, but as I said, the mobility of the patient is very much restricted with flexion deformity, and patient has to use enormous extra energy to move. So in combined deformities, varus and valgus, you have to do other releases also. So this is a patient with a rheumatoid arthritis, flexion deformity, both knees. So you can see the very clear what is called the notch view. And this deformity could be corrected easily. There is full deformity correction at the 6 weeks, you can see. And this is 3 months. So this is a patient with severe osteoarthritis, combination of flexion deformity and varus deformity. So you can see enormous osteophytes. So this enormous osteophytes means it becomes easier. Once you remove this bone, osteophytes, there will be relative laxity of the soft tissues and you can get deformity correction. So even here you can see we have ended up with thick insert. The insert is definitely 11 mm, I think. This is because the tibial cut should have been reduced, because once after removing all the osteophytes, you find that the space is more. So if you find a lot of osteophytes, you don't be in a hurry to do more bone cuts. You always go with a conservative bone cut. If you see, number one, a lot of osteophytes, and number two, there is a lot of lateral opening, for which you are doing a compensating medial release. That means you have to do less bone cuts. So this is from the frontal view, you can see the varus deformity is corrected. And from the side view, you can see that the flexion deformity is corrected. Right. So in summary, for varus knees, these are the things what we have to do the correction: removal of the medial side osteophytes, releasing of superficial and deep MCL, pes anterior tendon, and in some cases, reduction of osteotomy, medial defect grafting. And whenever you are doing medial defect grafting or reduction of osteotomy, you have to use a stem. And sometimes condyle sliding osteotomy is of help. And in FFD knees, you have to understand that post-op recurrence is common and sprinting is mandatory and supervised therapy is mandatory. So at the end of 2 months, if the patient is walking straight upright with no FFD at the hip and the knee, then you can discard the splint. So these are the release what we have to do in case of flexion deformity of the knees. Right. Okay, thank you. I will stop here. If there are any questions, yeah, you're most welcome to ask.
Sir, thank you very much, sir, for this wonderful talk. Right from the basics and demonstrative cases. In spite of having a bad flu and a bad throat, actually you did quite well.
Yeah.
You haven't recovered fully, I can see that.
Yeah, this is extended URI.
Okay.
Current, you can say this is a new influenza virus, or you can say it's a variant of COVID, whatever it may be, we don't know. But this is really troubling. Actually. I have not gone to school for 2 weeks.
Oh.
Right. So any questions, any doubts, anything clarification?
Sir, I'm sure there will be a lot of questions. Let me start with the questions actually. Now, how do you assess the severity of lateral laxity in a varus knee? In the clinic or after anesthesia or after your cuts, how do you do it? And how do you deal with it? You said that you take conservative cuts.
Yeah.
Conservative cuts, but this lateral laxity is something which easily gets away, and we suddenly are caught with it in the middle of the surgery, and suddenly everything opens up. And even after having, as you say, even after trying to do the trial, we find that laterally it's still opening. So
yeah. So assessment, as I said, it is initially clinical. You can see clinically the patient is walking with a significant varus thrust.
Yeah.
Number one. Number two, obese patient. This is the clinical side. Then number two, X-ray. X-ray, how much is the lateral subluxation? Where is the lateral femoral margin and where is the lateral tibial margin? If the lateral tibial margin is too much away, that means it is subluxed. That means there is lateral stretching is there. And sometimes there may not be subluxation, but there will be a lot of lateral opening. So this is the X-ray you can see. And so in these cases, as I said, to some extent, we are matching the lateral laxity by doing the medial release. But we cannot do complete matching. Complete matching means it is not possible actually. So you have to achieve a good deformity correction. so that when the patient walks, there is a good mechanical axis maintenance is there, and there is not much stretching on the lateral side. There should not be any residual varus deformity. That is the most important. If there is a lateral laxity, the deformity correction should be perfect. Otherwise, if there is, for example, if a tibial component is in mild varus, maybe 2 degrees. So what will happen after some time? The component may not move, but lateral side will start again opening. So after some time, the tibial component will sink. That's what happens. So that's why I said, if you think the lateral laxity is more, and if you think the patient is obese, you use intramedullary jig, which will give a perfect 90-degree cut to the long axis of the tibia.
In case of a tibial bowing, the intramedullary jig works because all these obese patients have a
bowing. Yeah, it works. It works. Yeah, tibia vara is there, but it works even if it goes to the up to 2/3, it is fine. It will not go up to the depth. And again, some of the cases I have used, as I said, I always do the tibial cut first. I have used even CM just to check that my correction is correct. Proximal tibial cut is correct. And because as I said, we have released the medial thing, you take less tibial cut so that you can compensate with the adequate insert. Even after taking less tibial cut, you may end up putting 11 insert. That is okay. But even after putting the 11 insert, the leg looks dead straight. Now you give again some varus stress. Again, still there is some lateral opening. So you don't bother too much. If the patient is walking in the correct mechanical axis, no varus, generally the lateral ligament may get tightened up for a period of time.
Exactly right.
Or if you are concerned, you use a dialed knee brace, where it will prevent the lateral opening up, especially in obese patients we can use.
So some very little amount of lateral laxity we can ignore, or we can just accept.
No, we can ignore. There will be some lateral laxity in many patients.
Because physiologically we have lateral laxity.
We have in many patients, especially Asian patients, as you know, there is a varus tendency. The knee itself is designed in varus, in Asian knees. So there is lateral laxity. And most of the patient is sitting in the floor cross-leg and squatting. And especially sitting in the floor cross-leg. These cross-leg sitting patients will have a lot of lateral laxity. So we need not bother very much. We have to see that the deformity correction is good. You should not attempt a so-called anatomical knee here or a kinematic knee here. You have to go for a mechanical alignment here.
Thank you, sir. Sir, you showed cases where you did grafting, and some cases just only the stem. So when do you choose between the graft and only cement and stem for a medial tibial defect?
No, generally when I do grafting, if I think the bone quality is good, I may not use stem. But if the bone quality is bad, if the patient is obese, generally grafting has to be supported with the stem. If you are using a medial wedge augment, or if you are doing medial bone graft, then better to use a stem. Right? As I said, stem again protects you from minimal varus malposition, especially in the lateral axis. Generally graft. Yeah.
No, go ahead, sir. I'm just looking at questions here. Yeah, go ahead.
Yeah. So only stem I rarely use. I have used in these patients where there is a trauma. In trauma patients, I'm a little bit skeptical because that's the three-dimensional deformity has happened in the medial tibial condyle. The medial tibial condyle has slipped in the varus and also posterior. And the plate the implant what we use, it looks like good, but sometimes if there is not much remodeling of the bone, it may sink later. And that patient I showed it, the patient is 70 plus. So there is no harm in using a small stem. Otherwise, generally, stem is not mandatory in all the cases. If you can achieve a good balancing, stem is not mandatory. Stem is mandatory if there is a bone defect. But the defect is more than 2 or 3 mm, you have to go for bone grafting. If it is only less than 2 mm, you can use only cement.
Oh, anything more than 2 to 3 mm, you will graft it.
Yes. You make the defect 3 mm, you just use osteotomy, you make it 4 mm, and then you put a bone piece. You can put at least 1 screw. And sometimes you can get away with reduction osteotomy, but sometimes you cannot. Then you do the graft. But most of this graft, they take very well. So I don't use, I hardly use wedges. That's a cumbersome procedure according to me. You have to remove a lot of bone. This is relatively simple. You put a piece and then you put 2 screws and then cut it, becomes much simpler.
How often have you done the lateral advancement osteotomy for?
Actually, I have not done. I have not done a single case, but I have seen 2-3 surgeons doing, but it's not routinely done.
Yeah, no, in fact, I was surprised to see that we could show a case because we've done a few medial epicondylar osteotomies, but lateral osteotomy for varus knee, I think I'm hearing,
advancement,
I'm hearing it from you only. Probably we can use it when there is a similar.
No, it is same like valgus. You have to be careful when you are dealing the condyle, which is opposite deformity, because that condyle will be osteoporotic.
Yes.
So this condyle is sclerotic, that condyle is osteoporotic. So you have to take a relatively big fragment and you have to pull it proximally, and then you have to fix it with the screws. You have to use washers. Whatever said and done, they say our physician is good, but generally people will tell. But if I am doing any osteotomy like that, then I have to support with a hinged knee brace and a dialed knee brace. And many times I will not allow the knee flexion for at least 3 weeks.
Thank you very much, sir. I think we've got a couple of cases. Dr. Adarsh,
Any other queries from anybody else?
any questions? There is a question. Is intraoperative hyperextension advisable in FFD correction?
Definitely not. Dangerous deformity. You can allow some flexion deformity at the end of the surgery because you can stretch out by regular therapy. You cannot allow any degree of hyperextension at the end of surgery. Should not. Dangerous deformity. Hyperextension is a dangerous deformity.
Sir, can
progress?
you unshare your screen, sir? Sorry, sir. I just
Sorry, Okay.
Adarsh, you share your screen. Yes, sir. Please, sir. Here you were talking about hyperextension.
Yeah, hyperextension deformity, it's very difficult to deal. So you should never leave hyperextension. The moment you say hyperextension, you have to go for a thicker insert. You have to go for a thicker insert.
Okay. And there is another question. Metaphyseal varus and tibial stem implantation. What are the tips?
See, metaphyseal varus, again, how much is the varus? We have to see. If the patient has got what is called a stress fracture and the deformity is more, then you have to do a complete osteotomy there. And then put the tibial implant and use a relatively longer stem. So that the idea is you have to get a good deformity correction. The metaphyseal varus is relatively small. You can try to correct that at the joint level. That's what I have told very clearly. What are the components of deformity? You should know which level. I think if it is less than 10 degrees, you can try to correct it at the articular level itself. And again, intramedullary device has to be used to cut the proximal tibia in these cases. You have to see that of course, we are going to use an intramedullary rod, and you use the proximal tibial cut, do the proximal tibial cut by taking an intramedullary device. And you have to be careful where the stem has to come. There can be remodeling difference will be there. Again, try to use CM so that your intramedullary rod, where it exits, there you have to make an entry point. The entry point, you may think it is correct from the knee joint, but it may go and touch the some cortex on the medial side. So the entry point has to be lateralized. You have to be careful.
In time and again, Dr. Satish sir emphasizes on the use of CM intraoperatively, and I think it's a good. It will be a good addition in this.
Yeah, many surgeons they have CM, but they don't use. They use only for trauma. They think knee replacement is not. It cannot be. Need not be used. But if we have a gadget, I think it is better to use. Yeah,
it's an important.
Be more confident. Yeah.
Any more questions? Ganesan sir, Vijayaraj sir. Okay, so if there are no more questions, we'll go for just 2 case presentations quickly and then we'll call it a day. Adarsh?
Yes, sir.
Yeah, please go ahead.
Good evening, everyone. We'll see a couple of cases that were done at Case Ortho today to see how we could go ahead and what we have done. So, the most common methods used for correcting a varus deformity in a TKR soft tissue procedures include the selective posterior-medial release and bony procedures, which is reduction osteotomy and the medial epicondylar osteotomy. So our experience with these 2 procedures have been, first case, the 63-year-old female who presented with pain and instability of the knee, insidious in onset and gradually progressive. Her quadrilateral limb had a post-polio residual paralysis. Local examination findings were no significant joint swelling. She had joint line tenderness. She had a range of movement of 10 degrees to 90 degrees with an FFD of 10 degrees and a varus deformity of 32 degrees. There was no distal neurovascular deficits on this limb. So this is the preoperative X-ray, which shows significant varus deformity with lateral subluxation, with significant patellofemoral ova and medial osteophyte and posterior osteophytes.
Satish sir, how will you address this case?
See, the enormous posterior osteophytes suggest that there will not be any problem in the flexion deformity, right? So it is basically the varus thing. Again, medially also there seems to be a lot of deformity. So once you remove the osteophytes, the deformity can be well corrected, but there is a lot of lateral subluxation. As I said, you can see these margins. The lateral margin is this much, and this suggests that there will be lateral stretching will be there. And as I said, you have to take a little bit less of maybe distal femur cut and proximal tibial cut, 2 mm less we have to take. You do a medial release, do all the osteophytes, do a medial release, then take 2 mm less cut, 2 mm less cut. Now go for a spacer and see what is the gap balance.
With a varus of 32 degrees, would you consider doing an osteotomy early or would you do it after all the releases?
No, after osteotomy is last.
So you do all the releases and then decide on osteotomy.
Yeah, all the releases in these cases it may look very tough. As I said, more osteophytes are present means I am happy. That means once you remove the osteophytes, the ligaments will be relatively loose, and we can able to achieve the correction. So I think reduction osteotomy. What osteotomy you mean? Reduction osteotomy you mean, or epicondylar
slide?
Epicondylar slide is only in rare cases. Epicondylar slide only in rare cases. Generally do not do epicondylar slide because it is easily said. But the moment even if you slide, the fragment comes down. You have to lateralize the component. It may hinder the insert. That component. I mean the bone piece will come and it will hinder the component. So you have to nibble that, and the fragment becomes relatively thin. You have to use 2 screws. Again, you have to immobilize. So I think unless it is needed, if you do a good, this patient requires a good entire medial thing has to be skeletonized. The medial tibial condyle has to be skeletonized, anterior to posterior. Then you will get a full correction.
Okay. Others you can proceed. Yeah.
And
Yes.
this one thing I just want to tell you, this broken osteophyte is there. This is the thing you have to be careful, as I was telling repeatedly. If you are a little bit careless, the moment you try to remove this, you will cut the MCL. Suddenly everything will get opened up on the medial side. So this osteophyte on the medial side, the release you have to be always doing as a sleeve. And this osteophyte you have to very, very slowly you have to remove. Little bit harsh, then means you have cut the MCL.
Yeah, I think it's an important take home. Yeah. Okay, go ahead, Adarsh. I think I'll show what we did. See, this was
the immediate post-op X-ray.
Yeah. So this was a weight-bearing limb for this lady, and she was not able to walk for almost 3 months because of the severe deformity. The other limb is flail. She works as a teacher, and she was working, and she came with a walker, inability to walk even with a walker with one leg because the other leg is very flail. So intraoperatively, after releases, we found that there was still medial tightness, and was a little hesitant because of all that lateral laxity. This whole point about lateral laxity, as Dr. BRJ was mentioning, it becomes very important, because you have to take less bone, otherwise you will end up having a huge gap, and then you will end up putting bigger inserts and then more releases, and then there is no end for it. Especially in patients like this, where if you remove the osteophytes, the tissues, they are a little lax, so you have to be very careful. So in this patient, we did a medial epicondylar osteotomy, and it made our job easy. But as you see, we have put a thicker insert. That's because we had to compensate for the lateral laxity, and we left the patient in about 1 or 2 degrees of lateral laxity here, and we added the stem, but I haven't put a graft. There was I did a little bit of reduction osteotomy on the tibia. There is no defect, but I just added a stem just in case, because this bone was porotic as well. So this patient has done well, still walking with a cane. Yeah, go ahead.
So one comment, yeah.
Yes, go ahead.
So as I said, so the moment we think of doing a medial femoral condyle osteotomy, the femoral component, see, there's a slight lateral shift.
Yes.
And at the moment you're doing a box cut, the lateral condyle itself becomes very small. You have to be very careful. The lateral condyle itself becomes very small because you have cut this and you're going to take a box cut. So in bigger knees, the problem will be less. In smaller knees, we have to be careful. It can be done, but we have to take extra precautions.
You know, the condylar osteotomy has become more from an epicondylar osteotomy to a condylar osteotomy, because we take a thick slice.
It has never been epicondylar osteotomy. It is just the name, but it is actually a condylar osteotomy.
We take a very thick slice so that fixation becomes easy, and as
you can see the line here, it is gone up to here. That's how we have to do that. Yeah.
And as Dr. Satish was mentioning, the fragment slides inferiorly, so you'll have to nibble off that inferior bone so that the component sits without any problem. And what we noticed is there is some flexion opening after medial epicondylar osteotomy. The flexion gap opens more than the extension gap. I don't know whether you found the same thing.
No, it depends. Most of the time, this fragment gets pulled posteriorly, then the flexion gap gets opened up. The fragment, not only if you have to, it is very difficult to move the fragment only distally. Even though you say distal advancement, along the distal advancement, there is some posterior advancement. We are not advancing, but actually it slides.
Yeah.
It slides, then the posterior gap becomes increased. Yeah, that's what happened.
And you fix the osteotomy in flexion, sir, or extension?
See, it depends which gap you want or you do not want. So if you think the flexion gap is correct, you flex this. No, but basically we are doing it for extension, so we have to do it in extension. Only thing is, in extension, the fragment should not slide posteriorly. If it slides posteriorly, the flexion gap will be there.
Okay, so we'll have to make sure that it is slightly an anterior and then fix it in extension.
Extension, because the idea is to get the extension gap. I mean, to correct the varus, no? Yeah.
Yeah, fantastic. Excellent. Proceed, Adarsh. We got 5-10 minutes more.
So this is a post-op follow-up after 3 months. This patient walking with a cane with full weight bearing on the limb, and she seems very comfortable with the procedure right now.
Okay, go ahead.
The next case is a 65-year-old female presented with pain and instability of the knee, which is again incidence is often gradually progressive. Her contralateral knee had a valgus deformity, so effectively she had a windswept deformity of the legs. The local examination showed no significant joint swelling. She had joint line tenderness. ROM was 10 to 100 degrees with an FFD of 10 degrees and a varus deformity of 16 degrees. So this was the preoperative X-ray, which is showing significant lateral subluxation of the knee, about 16 degrees of varus deformity and significant patellofemoral OA. Not much posterior osteophytes noted on the pre-op X-ray.
Have you got the scanogram?
Yes, it's at the end as a comparative between the two, pre-op and post-op.
You can show the scanogram, it's fine. So this is a windswept deformity
Yes.
with very minimal osteophytes, as you mentioned. This is the second scenario where there are not many osteophytes.
Hmm.
And this patient had a significant medial defect, and I had to okay, go to that. This we did a lateral parapatellar approach for the right knee. Right, it's a windswept deformity.
Okay.
Right knee we did a lateral parapatellar. So actually here I just use screw and cement actually. Do you
Okay.
do that?
Yeah, this is described, but I generally don't do this. Yeah.
You usually have a. I think I put a graft. I'm not even sure.
Yeah.
It's about 3 months back. I'm not. I think I put a graft and a couple of. But, yeah.
And my comment is, see, in all these cases,
Yeah.
you see the pre-op itself, we have seen that there is a lateral subluxation.
Yeah.
So whenever there is a lateral subluxation, whenever there is a lot of lateral opening, whenever you think there is a lateral laxity, you have to use a PS now. CP surgeons may differ, but there is always a chance when the patient is loading, there is a chance for lateral subluxation. It may happen slowly over a period of time. I think here you used a disc insert.
Yeah,
Right. I generally do not do this disc insert whenever I see lateral subluxation. It's always a PSC.
Okay, I think it is a valid point, and we will take it home to this. So when there is lateral subluxation, you better go for PS rather than.
Yeah, that gives a mechanical block in the initial phase till the lateral side gets a little bit tight. This cam and post will prevent the minor lateral subluxations.
And this was a windswept deformity. This knee was done 3 months back, and we've done the valgus knee recently. And this
This is 3 months post-op of the ipsilateral knee when she was planned for the contralateral knee procedure. So this is the X-ray of the contralateral knee showing the valgus deformity.
Okay.
fixed valgus. Clinical, surgical fixed valgus.
Yes.
Valgus. And this is the post-op X-ray of the contralateral knee after valgus correction.
Right.
One interop thing I noticed was we had a little difficulty in visualizing the posteromedial corner here.
Yes.
So you can see that the component is slightly laterally placed.
Lateralized.
And after in posterolateral in parapatellar lateral parapatellar approach, we didn't actually evert the patella. We just subluxed it and kept it in the medial side. And there was, I think that's the intraop. It looked all right, but on the X-ray I could see some medial uncovering the tibia.
Yeah, I think you have not done quadriceps snip.
No, I didn't do quadriceps.
So that is the thing. So as I always say, if you're doing a lateral approach, you should not worry about it. The purpose is to do the job as best as possible. That's all. So you can do a quadriceps snip. You can see the tibia very well. It is the femur very well. Then you do that because it is only a muscle thing. It is going to heal in 3 to 6 weeks. Our idea is this knee has to work for 25 years. So you do not bother about 3 to 6 weeks.
Okay, sir. But we did it was good. Patient is comfortable walking around without any problems.
Yeah.
Good. We can go to the scan.
Nicely done. Yeah.
So it's
This
fine.
is the post-op scanogram.
Any questions? Any immediate questions to the speaker from the panel? And I can't see any questions here.
So how much valgus, distal valgus cut you have taken on the right side and how much you have taken on the left side? Distal femur cut. Well, what was the valgus angle?
1 degree, 2 degrees on the right side, and
Okay.
5 degrees is the notation.
Okay.
Left side was standard 5 degree.
Okay.
Do you do that, sir? Do you change the valgus?
Generally, I don't. I will check the angle between the anatomical and mechanical axis, and I will generally I will take that. 5 degrees I will take. Exnotation I won't change. It is exnotation is only standard external rotation. I don't take extra external rotation. The moment you do the lateral approach, you need not do extra external rotation because patellar tracking won't be a problem. So sometimes you reduce the valgus angle. Generally, you keep 5 or less than 5.
Okay.
But here there seems to be bowing. Left
Yeah.
side, I think the angle between the anatomical and mechanical axis will be 6 or 7. That's why I was asking.
Okay, sir. I kept it as 5 only, standard this thing.
So there is nothing called standard. I think we have to measure.
Every time.
Measure every time. So you have got the X-ray. So in the X-ray itself, you have the CM. I mean, the X-ray room, you can measure the angle between the mechanical axis and the anatomical axis of the femur.
And then keep that angle.
You give the angle. So there is a software. You can go to the X-ray room. Anybody can do it. It's easy.
There is a question. How do you correct rotational deformity associated with varus and flexion? From Kishore.
See, rotational deformity, as I said, most of the varus is associated with proximal tibial rotational deformity. So the so-called rotational deformity is happening at the joint level. We are not talking about the torsion deformity where the distal tibia is rotated compared to the proximal tibia. So that is different. That is the remodeling deformity that is seen in dysplastic valgus knees. But in a varus knee, what we generally observe is proximal tibia internal rotation. And now you do the proximal tibial release, you do external rotation, and then you sublux. Naturally, it gets better after the proximal medial release. And you keep the femoral component and tibial component in correct rotational alignment. That corrects the rotational deformity, whatever is there at the joint level.
You don't need to worry about torsion in tibia.
Yeah, torsion. I think we need not bother too much unless it is very severe. As I said, in varus, the torsional deformities will be less. You may have some tibia vara down, but in valgus and some of the dysplastic valgus, there is a significant torsional deformities compared to proximal tibia and distal tibia. There is definite rotational deformities there. In those cases, you have a little bit confusion how to exactly keep the tibial component dialed in for the proper rotation. And when you have got doubt, you keep it in slight external rotation. That's all.
Can we just have your literature review, couple of slides, Adarsh, quickly, and then we'll wind it up?
Yes, sir. So regarding selective posteromedial release, Mulaji et al. Is in their paper titled Correcting Valgus Deformity, published in 2007, they were able to achieve a correction of 22 degrees of varus to 5.38 degrees of valgus. So their protocol was they released the deep MCL first, excised the osteophytes, and in most cases released the semimembranosus. Followed by they performed a reduction osteotomy of the posteromedial corner of the tibia. If this did not correct, then they released the superficial MCL. Only in cases of recalcitrant contracture did they release the pes, and then they reattached it back to preserve the flexion stability. Mulaji et al. In 2014, in their paper called Correction of Valgus Varus Deformity during TKA using reduction osteotomy, they were able to achieve a correction of 1 degree with every 2 mm of osteotomy. So this positive correlation was significant only in knees less than 15 degrees of varus, because in knees with the varus deformity more than 15 degrees, they were associated severe medial soft tissue contracture, excessive lateral soft tissue laxity, and associated extraarticular deformity. Nikki Y and et al. In their study on effects of reduction osteotomy on gap balancing during total knee arthroplasty for severe varus deformity, published in 2015, they were able to achieve about 1 degree of correction for every 4 mm of valgus reduction osteotomy, and up to 2 mm on 8 mm of osteotomy. They did not need any further additional soft tissue release. For 20 of the knees, only reduction osteotomy was enough. They could preserve the superficial MCL and the pes insertion. Mirzatulio et al. In their study on primary results of medial epicondylar osteotomy in patients with severe bilateral varus knees, they studied 14 knees. In one knee, they conducted an osteotomy, and in opposite contralateral knee, they did a pie casting. They were able to achieve similar results in both the procedures. So they concluded that osteotomy was a safer procedure and a more controlled procedure compared to pie casting in correcting their varus deformity. Orban et al. In 2000 12, in their study, medial epicondyle osteotomy, a method of choice in severe varus knee osteotomy, studied 60 knees. 30 of them underwent medial epicondyle osteotomy and 30 of them underwent tibial medial plateau resection. Their outcomes were very similar in both these groups. So they concluded that MEO has a better advantage over medial reduction osteotomy of the tibia because it preserves more bone stock following, which would aid in a revision surgery. And they also commented that they did not need to reattach the resected medial epicondyle. Mulaji et al. In their study using computer-assisted sliding medial epicondylar osteotomy to achieve gap balancing, in 2013 were able to achieve mediolateral laxity correction from grade 2 or grade 3 to grade 1 in all their knees up to last follow-up. The mean knee society score improved from 30 to 92, and the mean flexion improved from 106 to 112, and no knee had any extension lag or residual flexion deformities. Sim J. et al. In their study on clinical and radiological evaluation of medial epicondylar osteotomy for various total knee arthroplasty in 2018, were able to correct varus deformity of about 10 degrees to a valgus deformity in up to 5.5 degrees using medial epicondylar osteotomy. Similarly, they were able to correct the mechanical axis correction from 16 degrees varus to a postoperative varus of 1 degree at the latest follow-up. Thank you,
sir. Thank you, Adarsh. I think the most important take home is that you have to clinically evaluate and then intraoperatively after anesthesia again evaluate and then go slow step by step as Dr. Satish said. Most of the knees can be easily done with soft tissue releases, and then if not possible, then you can go for a reduction osteotomy on the tibia. And in extreme cases, you can do a epicondylar slide osteotomy. And with the FFD again, I think there were a lot of important take-home messages. Preoperative assessment and preoperative sprinting can help you intraoperatively, because if you don't do that preoperatively, you will end up with a very big flexion extension mismatch, because the patient will have a very small extension gap and a huge flexion gap if you go in with a flexion deformity, and then you will end up cutting more bone and releasing a lot of tissue so that's an important take home as well. Any more questions? I think we got preoperative assessment and preoperative because if you don't do that any more pressing questions, or shall we close? Sir, Sundaraj sir, Ganeshan sir.
How do you say you can avoid the fixation of the medial epicondyle after osteotomy? Explain.
Sir?
Can you hear me?
Yes, sir. Yes, sir.
How do you get away without fixing the medial epicondyle osteotomy?
And that was an interesting article recently, sir. I think they claim that even without fixation, it will heal. It will just stabilize and heal. Many times, sir, when we slide the osteotomy and we put the insert, the knee is very stable even without any fixation. Fixation is just for our, it's for prophylactic purposes, I think. So in that study, they didn't fix, and they found that even without fixation, it heals.
Will you avoid the fixation in your case?
No, I'm not. I will put two screws.
Thank you.
There are no more questions. I would like to thank Dr. BRJ Satish for this enlightening talk. He is known for enlightening talks, and he has kept his standards in this talk as well. So thank you very much, sir. Thank you for being with us. And this whole talk will be available on YouTube for future views as well. And I thank OrthoTV, and I thank all the panelists and viewers who who have been with us. Thank you very much.
Thank you.
Thank you. Sir Ganesan sir, see you. Thank you. Bye-bye.
Thank you very much, sir. Thank you for taking this. Whole talk will be available on YouTube for future views as well. Thank you very much.
Zoom go auto TV difference time.
Sir, thank you. Thank you.